for today's CME program.
Yeah. So thank you for this great.
No, you can start, madam.
Yeah. Good evening, one and all. So, and thank you to JP Pharmaceuticals for this great opportunity to discuss the breadwinner of topic for all the physicians, that is the hypertension. So I'm going to discuss about the basic things and what is the prevalence of the hypertension and what are the different aspects of the hypertension to be managed in a simple way. Let's move on to the topic. Okay, is it moving, brother? Is moved to the next slide?
Madam, slide more. 1 second, madam. Yes, madam. Now it's moving, madam.
Yeah, okay. So the basic things about the hypertension is all over the world, around 1.1 billion adults have raised the blood pressure, of which less than 1 in 5 have the under control. This is as per the WHO healthcare data. So why I'm telling this one is the prevalence and the huge problem of the hypertension. So the hypertension in India need the special attention because the large number of the people suffering from hypertension are lost to care. So actually they conducted one survey around 731,000 people aged 15 to 49 years across the India showed this following data, of which 76.1% screen at least once in their life. Okay, most of the people they may not aware, even they need to routinely check the blood pressure. And 44.7% aware of the diagnosis, and only 13% got treated, and 7.9% had the BP under control. So what is the trend of hypertension in India? As previously told, 70% of the Indians with the hypertension unaware of the condition. And once they diagnosed only when they're going for any screening for diabetes and routine screening for hypertension or under the master health checkup, something like that, when they routinely do a BP checkup, only they will came to identify that they are hypertensive. India is one of the lowest rate of hypertension diagnosis in the world, and low diagnosis in India results in the low treatment rate. India's hypertension treatment rate is 1/3 lower than the global average, but our country has the highest population, but with the lowest diagnosis of the hypertension. India's treatment rate is lower than nearly 80% of all the countries. Undetected and untreated hypertension is one of the key reasons for India's high burden of CV disease. Salt intake in India has increased tremendously over the past 2 decades. Actually, we, the Indians, always go towards the spicy food and rich in the salt. That is the routine for our culture, but that itself is very dangerous for our health too. The Indian hypertensive patients have the not only hypertension but has the multiple comorbidities. Actually, the multiple comorbidities double the cardiovascular risk complications. Our Indian patients are most of the time they are younger patient. They're living a stressful life. They're detected as a hypertensive. And when you check very closely, most of the resting heart rate is around more than 85 beats per minute. Actually, this is it's not good for the healthy lifestyle. And slightly more prevalence in the urban, 33% than rural, 25%. This is a simple example is in urban, most of the time they end up in a traffic, pollution, and time management. Routinely, they are really stressful. In rural also it's there, but still some comparatively when compared to the urban, rural is lesser than 25%. And most of the time they are living with a comorbidity. So always hypertension is associated with either diabetes or cholesterol. And early signs of the CKD endocrine damage in hypertensives. And as a more in men, 14% than in women, 9%. And large chunk of patients are unaware, untreated, and uncontrolled. So hypertension is a gateway for cardiovascular disease. So this is the importance of treating the hypertension. Why we need to treat the hypertension is, so we should treat not only hypertension, we are preventing the other organs from getting damaged. For example, the hypertension associated with other risk factors like a diabetes, obesity in elderly means they lead on to the atherosclerosis and left ventricular hypertrophy. Atherosclerosis is deposition of the cholesterol in the vasculature, and left ventricular hypertrophy. So that move on to the myocardial infarction and stroke in later, and again cardiac remodeling leading to the cognitive dysfunction, ventricular dilatation, congestive heart failure and stroke, even the cerebrovascular death. This underlying pathophysiology is nothing but because of the hypertension, the endothelium is get damaged, leading to the microalbuminuria, macroproteinuria, nephrotic proteinuria, and end-stage renal disease. So if you see this, brother, you can mute others. Orbit.
மேடம் அது நீங்க தான் மேடம் பண்ண முடியும்.
Okay, okay. Okay. So about 3.5% of the premature death worldwide are attributed to the high blood pressure. So if you see 3.5% premature death because of the high BP, and 54% of the stroke and 47% of the ischemic heart disease are attributable to the blood pressure. So whenever you see in a ward, whether a stroke patient or cardiac failure patient, when you ask the past history, the patient definitely must be a diabetic or hypertensive. For all the stroke patient, heart failure patient, majority the hypertension is a culprit, leading to the morbidity and mortality. So these are all the major complications of the persistent high BP. So if you see the organ wise, in case of the brain, it leads to the stroke and hypertension, encephalopathy. In case of the bladder, elevated sugars and hypertensive retinopathy, heart failure and kidney damage. So all the end organs is getting damaged when there is a elevated BP for a long time. So hypertension is a major preventable risk factor for atherosclerosis and ischemic heart disease. Once there is a word of a preventable risk factor, this is our duty, that is the healthcare practitioners, to detect the hypertension early and to avoid the stroke and then heart failure in future. So every 20 mm elevation in a systolic BP, normal is 120/80, above 120, 20 mm elevation of the systolic BP and 10 mm elevation of diastolic BP actually double the risk of the cardiovascular disease. So tight BP control is necessary to prevent the cardiovascular disease. So why we need to control the BP? What are all the benefits? Actually, if you closely see, 40% reduction in the stroke incidence. The 40% is a big number, because if you prevent the stroke means actually it helps the, suppose one father has got a stroke means the family members, total family members will succumb to the sufferings, and they will lose the income, and if they are dependent to the father. So this 40% reduction, it helps to most of the families to live in a normal life. And also 20 to 25% reduction of the myocardial infarction, and more than 50% reduction in a heart failure. This 40, 25, 50% is a big number. That is the importance. We need to control the BP as early as possible. These are all the overall importance of reduction of a 5 mm Hg reduction in the systolic blood pressure helps to reduce the cardiovascular and stroke, heart failure, all the risk. Hypertension and then the comorbidities. So challenges in the management of the hypertensive patient with the comorbidities, because in our country, not most of the patients presented with the hypertension, always they'll be presented with either hypertension diabetes or hypertension with the dyslipidemia or hypertension with the heart failure. So when you should treat not only hypertension but also associated with the comorbidities. For that, we need to talk to the patient. What are all the importance of treating all the comorbidities? And also most of the elderly patient, they will definitely present with the comorbidities. They'll be worried about polypharmacy. Even they will ask, எவ்வளவு மாத்திரை டாக்டர் நான் எடுக்கிறது அப்படின்னு சொல்லிட்டு, even they will ask for the multiple tablets for so many diseases. So we need to treat that. So this is the flow chart for when the increasing age, the prevalence of the diabetes with the hypertension is also in the increasing trend. This variety of the factors contribute to the development and severity of the hypertension. Why the hypertension is in the increasing trend? Because of the salt intake and urbanization and dietary habits. Most of the time we are eating the fast food, junk foods and oily foods, and seasonal variation, all these things. Diabetic hypertension in India. So actually, diabetic with hypertension is not a sweet information. India has the second highest number of the diabetes patient aged 20 to 79 years as of 2019. Here you see China in the top 100 million population diabetic with hypertension. India is the second topest, 75. So we need to very much concern to control the diabetes and then hypertension. So the same thing. So the diabetes and hypertension is increasing prevalence in the younger population. 1 in 5 people suffering from the diabetes and 1 in 4 people suffer from the hypertension is very common. The presence of both the diabetes and hypertension increases the risk of the cardiovascular disease 75%. So if the patient, even if you see our parents, father or mother, they are presented with both the diabetic and hypertension, so they are very risk for the cardiovascular MI 75%, and also they are very risk for development of the CKD. The hypertension, kidney disease, and development of the cardiovascular disease, of how they are interrelated with each other. So if you remember, when the hypertension, because of the elevated BP, the vascular resistance, and because of this resistance, in meanwhile, there will be left ventricular hypertrophy and remodeling leading to the cardiovascular disease, and also because of the sodium retention, endothelial dysfunction, autonomic dysregulation leading to the kidney damage. This vice versa, it will circulate with each other. CKD is a highly prevalent and global disease, and that too because of the hypertension is the underlying major risk factor for the CKD. The high blood pressure and hypertension are independent risk factor for the development of the end-stage renal disease when compared to the optimal blood pressure. Majority of the time, hypertension is the main reason for CKD, and also sometimes diabetes with the hypertension leading to the CKD is also a risk factor. So how we need to diagnose? This is also very important. So whenever you come to record, this is for paramedical students, hope all the physician assistant emergency students join. So in OPD or ward site, whenever you are recording the BP, you should follow all these rules to get a correct blood pressure. So always we need the patient to be in a clinic or hospitals, ask the patient to be relaxed for 3 to 5 minutes before you record the BP and explain how you're going to record the BP. And so always before tying the BP cuff, always preferable is the left side, left arm in the heart level, 3 to 4 centimeter above the elbow joint, we need to tie the cuff. So always loosen the cloth. Don't tie the BP cuff over the thick cloth or sweater or something like that. That will give a false BP. And also we need to slowly raise the blood pressure, maximum about 140 or 150 or 160, and slowly 1 to 2 mmHg we need to decrease it. Once if we get a sound, so the pulsating sound in the recordings, that is a systolic, and disappearance of the sound is the diastolic blood pressure. So focus on the diagnostic technique for the hypertension. The two method of the hypertension management, that is the ambulatory BP and then the home-based BP. Hello, making the noise. Corvin, நான் உங்களை co-host ஆக்குறேன். நீங்க ஏதாவதுன்னா மியூட் பண்ணிருங்க.
ஓகே மேம்.
ஹோஸ்ட் ஒண்ணுதான் இருக்குன்னு நினைக்கிறேன். ப்ளீஸ் யாராவதுன்னா கொஞ்சம் மியூட் பண்ணிக்கோங்க. Okay. So ambulatory blood pressure and then the home-based BP monitoring. Here the ambulatory blood pressure is, we can identify the white coat hypertension, masked hypertension. White coat hypertension is nothing but whenever the patient is going for the clinic or hospital, so in that time when you record the BP, that time only the patient blood pressure is very high, 140 or something like that. When they are relaxed at home, when you record the BP is always normal. Sometimes I can advise the patient to get a home-based BP monitoring and record from the home average of 4 to 5 readings at home itself, and then come and show the notes. If they are under control, we need not to start the blood pressure, that also. So ambulatory BP monitoring will identify the white coat masked hypertension. And I don't know where is the sound. So widespread hypertension gets misdiagnosed. Please கொஞ்சம் mute பண்ணிக்கிறீங்களா யாருன்னு?
தீபிகா அப்படின்ற அவங்க கிட்ட தான் உங்களோட வாய்ஸ் வந்துட்டு இருக்கு.
தீபிகா ப்ளீஸ் கொஞ்சம் மியூட் பண்ணிக்கோங்க. தீபிகா okay. So widespread hypertension is get misdiagnosed as hypertensive and put on the antihypertensive medication, which increases the risk of the hypotension. So we should not start immediately once the widespread hypertension is 140 or something like that. If you start antihypertensive, they'll end up with a low BP. So always we need to check 2 to 3 times before you diagnose or brand the patient as a hypertensive. So these are all the hypertensive classification: BP, CV risk, and organ damage. If you see, the hypertension staging is stage 1, stage 2, and stage 3. Stage 1 is uncomplicated, stage 2 is asymptomatic disease, and stage 3 is established disease. In uncomplicated, if it comes under split up into 3. Without any risk factors, 1 or 2 risk factors is more than 3 risk factors. If more than 3 risk factors with the BP, high normal is 120/80, high normal is 130 to 139 and 85 to 89, and grade 1 is 140 to 159, 90 to 99, and grade 2 is 160 to 179, 100 to 109, and 3 is more than 160, more than 100. So if you see closely here in stage 2, they are very high risk. The stage 3 is nothing but the patient with the hypertension along with the diabetes and CKD with organ damage, means even 130, 139, 85 to 89 is a very high risk for them. For stage 2 is without any organ damage, but the comorbidities there, means this 140 to 159 is very high risk, whereas stage 1 is more than 3 risk factors with 160, 100 means is a high risk. Where this is what is conveying the messages. When the comorbidities and organ damage is there, even 130, 139 itself is a very high risk for them. So we need to control the BP. So office BP threshold for treatment. So this is the, for each age there is a threshold. We should target the blood BP under that control. So for 18 to 65 years, if the patient is diabetic, hypertensive, CKD or CAD or stroke, means we need to target for up to 140/90. For more than 80 years, even 160/90 is more than enough for them. We should not bring the BP to 130, something like that, to the more than 80 years people, because they'll go for a already they are aged, atherosclerosis there, the blood vessel will be stiff, so we should not expect them to be a very normal 120 BP. They'll end up in a hypotension. So hypertensive evaluation as per the ISH 2020 is, we should always ask for a history, detailed history examination, and rule out any drug-induced hypertension, and evaluate for the organ damage, and assess the cardiovascular family members or any MI or something like that. And symptoms, always think for resistant hypertension, means think for any symptoms and signs for the secondary hypertension. Secondary hypertension is nothing but in case of the adrenal cause or any tumor leading to hypertension, we need to search for and control them. And lab basic test is the serum sodium potassium to work out for the secondary hypertension, lipid profile and glucose to treat the comorbidities, and 12-lead ECG if associated with the cardiovascular risk. So additional tests we need to assess according to the any organ damage. So hypertension diagnosis, how we are going to approach this. So single office BP measurement. If you once the patient visiting to the hospital or clinic, if you measure, means if the normal BP is less than 130/85, then remeasure after 3 years. So actually 3 years we cannot wait for it. Even every 6 months or 1 year we can remeasure according to the risk factors. If the first BP is showing 130 to 139 and 80 to 85 mmHg in the systolic and diastolic, means take 2 more readings and use the average of 3 readings. If the average itself is more than 130/85, again remeasure in 2 to 3 office visit. If possible, confirm with the home and ambulatory BP monitoring for any master hypertension, white coat hypertension. Again, is more than 130/90 means you brand them as hypertension and treat them with the antihypertensive medication. Suppose the first reading itself, the hypertension is more than 140/90 means, so possible check the average and treat accordingly. So the importance of this slide is always if there is BP is means you go for 3 average readings before you brand them as a hypertensive, before you start a antihypertensive medication. Hypertension and then the comorbidities. So this will face in practice. Most of the time the patient will be very much obese. We cannot tie the BP cuff itself. The cuff size is very smaller for them. So in that time it give a falsely low BP or falsely high BP. It's difficult. So obesity and hypertension, at least two-thirds of the prevalence of the hypertension can be directly related to the obesity. Apart from hypertension, abdominal obesity has also been implicated in the pathogenesis of the coronary artery disease, sleep apnea, stroke, and congestive heart failure. So always, whenever you see a patient with the obesity, means you don't expect the patient to be only hypertensive. There will be associated much risk factors. We need to identify them. So the same thing. So the genes, because of the genetic and environmental factor, the patient will be an obesity leading to the oxidative stress, endothelial dysfunction, vascular effects because of vascular damage end up with the hypertension, and renin angiotensin system activation leading to the sodium and fluid retention end up with the hypertension. So obesity is a cause of the treatment resistant or difficult to control the hypertension. So if you look at this obesity and then hypoxemia or obstructive sleep apnea, there will be a chemoreceptor hypersensitivity. Chemoreceptor baroreceptor is nothing but that helps to control the BP. That is tonic reflex activation. Suppose the patient is very resistant hypertensive means we need to go for the carotid chemoreceptor denervation, or in case of the chronic means baroreceptor activation. So that will help to control the BP. Since it's not controlled means increased sympathetic activity means we need to go for the renal denervation to treat this resistant hypertension. So always the management is first is a diuretics, renin angiotensin system inhibitors, beta blockers. These we need to consider according to individual patient risk and benefits. The renin angiotensin aldosterone system inhibitors, that is nothing but like a enalapril, all these things, or the first line antihypertensive for most of the patient because of the broad spectrum of beneficial effects. Angiotensin converting enzyme inhibitors. For the student benefits, I'm telling angiotensin converting enzyme inhibitors is enalapril, ramipril. These are all the drugs. But before you starting these drugs, we need to check any renal arterial stenosis is there, because it's very dangerous when the patient with the renal artery stenosis, if you start AC inhibitors or ARB, actually is contraindicated. And also we need to check whether the patient is going for any allergic reactions or dry cough if there or not. If there means we need to switch over to the another group of the antihypertensive. But the patient with the diabetic and hypertensive means actually AC inhibitors, ARB is the ideal drug to control the blood pressure. Currently the most appropriate drug for the patient. ARB, angiotensin receptor blockers, losartan, all these things can be used in the patient who do not tolerate the AC inhibitors. Clearly, renin-angiotensin system blockage in patients with obesity-related hypertension is unlikely to worsen the glucose or the lipid metabolism. Beta blockers. Beta blockers is nothing but as a cardiac-selective beta blockers is a metoprolol, carbidiolol, all these things. It helps to reduce the cardiac output and renin activity, both of which are frequently increased in obese patients. Beta blockers alone or in combination with the alpha blockers were most effective in decreasing the BP in obese than in the lean hypertensive patient. So we need to select the group of the antihypertensive depending upon the type of the patient or any comorbidities or risk factors, all these things. But the disadvantage of the beta blockers is the limitation of the beta blockers, especially in any hypertensive patient without any cardiac or renal complication means, so there will be a defect in the glucose metabolism and body weight. When you start a beta blockers for young patients or something like that, they'll going for any hyperglycemia and a weight gain. So we need to keep monitor that also. The obese patient often have a metabolic abnormality such as a glucose intolerance, increased cholesterol concentration that can be exacerbated by certain antihypertensive, particularly beta blockers. That means if the patient is non-diabetic or non-dyslipidemia as that means better you avoid the beta blockers for the obese hypertensive patient. Beta blockers can also cause a weight gain or it may more difficult to lose the weight. So we finished obesity and hypertension and diabetes with the hypertension. Now move on to hypertension and coronary artery disease. BP is related to the fatal CAD over the BP range of 115 to 180 for all ages seen in the studies. So previously I told each 20 mm elevation of a systolic and 10 mm elevation of the diastolic BP actually doubles the risk of the fatal coronary event. Some current guidelines call for more aggressive BP management in the presence of other cardiovascular risk factors. So BP reduction without attention to other risk factors is inadequate to reduce the cardiovascular disease. Always we just once you check the BP, always check for any risk factors is there or not. So here you see already I told if you tightly control the BP or otherwise they will end up with the 40% MI risk I previously told. So 20 to 25% of the MI risk. So always we need to keep the BP under control, less than 130/80, and lower the lipid. The LDL-C target is less than 55 mmHg, and stop the smoking and diet. So and it depends upon the heart failure is there or not, we need to select the group of the antihypertensive. But all the hypertensive patients with the coronary artery disease start the antiplatelet therapy with the acetyl salicylic acid. So, but we need to individualize that also. If the patient is severe gastritis, a bleeding risk, we need to consider before starting this. Please mute some noise coming. So hypertension and then the stroke. So next we move on to the hypertension and the stroke. So this is very, very important slide. I want all the students to concentrate this slide. So the primary prophylaxis, when you to start the primary prophylaxis, patient with the hypertension should be treated with the antihypertensive drug to target less than 140/90 mmHg. Our target is less than 140 mmHg. Suppose the patient may develop a acute ischemic stroke, means if you're planning for any IV thrombolysis, means we need to reduce the BP of less than 185 110 mmHg. So any procedure also we need to reduce 185 110 mmHg. So before you're going for a thrombolysis in case of the acute ischemic stroke, but you should not tightly reduce the BP to less than 130 or something like that in case of the acute ischemic stroke, because they'll end up with the ischemic penumbra. So if you reduce too much of BP in ischemic stroke, means the perfusion of the blood to the ischemic area is still more reduced. The patient, the stroke will expand much more. So we should not vigorously reduce the BP in case of ischemic stroke. Whereas in case of the hemorrhagic stroke, in patients the systolic BP 200 to 220 to 150, and without any contraindication to acute BP treatment, means we can lowering the BP to up to 150 to 140 mm safely. Suppose the patient is more than 220 with the organ damage also, we need to reduce the BP with the IV infusion of the antihypertensive medication, mostly labetalol or metronidazole. So secondary prophylaxis means the BP therapy is, suppose the patient is undiagnosed of the hypertension but already developed the stroke or TIA, means again we need to keep the blood pressure less than 140/90 mmHg. And for patient with the recent lacunar stroke, means systolic BP less than 130 might be reasonable to target. So main concern is when the patient is the hemorrhagic stroke with the organ damage, means we need to immediately reduce the BP up to 150 or 140. In ischemic stroke also, suppose we are planning for thrombolysis, means we need to reduce the BP to less than 185 to 110, maximum 130 or 140. Don't go below 120 or something like that. Hypertension and then stroke, as per ISH 2022 guidelines, says hypertension is the most important risk factor for the ischemic and hemorrhagic stroke. So we need to control the BP for that. So always the target BP is less than 130 or 80. And going for the RAS blockers or calcium channel blockers, diuretic or first line of drugs, always reduce the lipid also. LDL-C is less than 70 mmHg. And antiplatelet we need to routinely start for ischemic patient, but not the hemorrhagic patient. Please mute. Some noise is coming from someone. Management and then the treatment, the lifestyle interventions. So this is the salt reduction, healthy diet, and actually there is no moderation of alcohol consumption. We need to stop the alcohol consumption, smoking cessation, weight reduction, regular physical activity, and stress reduction. What are all the goals of our therapies? Reduce the cardiovascular disease and renal comorbidity, and target BP is less than 140/90, and achieve the systolic BP, especially in the person is more than 50 years of age, and prevent the end organ damage. யாரோடது காட்வின் சொல்லுங்க, நான் மியூட் பண்ண சொல்லிடுறேன்.
மேடம் அது நீங்களே மியூட் பண்ணிடலாம் மேடம். பார்ட்டிசிபேஷன்ல போயிட்டு
யாருக்கும் தெரியல எனக்கு.
கிளிக் பண்ணி மியூட் பண்ணுங்க.
எனக்கு யாருக்கும் தெரியல, அதனால தான்.
ஆர்னு இருக்கு மேடம். வேற ஆர்னு ஒரு லெட்டர் தான் இருக்கு.
ஓகே, இருங்க நான் மியூட் பண்ணிடுறேன். ஓகே. So hypertension management guidelines is, first we need to start the dual combination therapy, that is the AC inhibitors or ARB plus calcium channel blockers or diuretic. Second step is the, if it is not controlling with this, we can go on for the triple combination, AC or ARB. I'm telling very specifically AC or ARB, not combine AC or ARB for a single patient. That's very dangerous. We should avoid that. Either AC or ARB plus calcium channel blockers plus diuretic. Still the BP is not under control, means resistant hypertension, means we can add a aldactone 25 to 50 mm Hg OD. Okay, still if it's not responding, means we need to work up for any secondary hypertension. So the beta blockers, importance of beta blockers is, we can consider beta blockers at any step when the patient is known case of a heart failure or angina, post MI, atrial fibrillation, or a young woman, or planning for pregnancy, means the beta blockers can be added if BP is not under control at any stage of the therapy. So monotherapy versus combination therapy. What is the importance of monotherapy? If you start only a single drug, any amlodipine or nifedipine, any single drug, means the patient is only the mild anti-hypertensive effect will be obtained. The reduction in the coronary events is 29%, whereas cerebrovascular events is 40%, and not much effect on organ production. Only a gradual or mild BP reduction may be there. But when you start with the combination therapy, means 5 times greater antihypertensive benefit is there, and 40%, yeah, 29% coronary events is 40%, and cerebrovascular 40 to 54% reduction of the stroke, and better organ production, faster and more effective control of BP. And multiple drugs have independent benefits apart from BP reduction, like anti-inflammatory and metabolic effects. So this is my last end of our presentation. This very important slide, I want everyone to concentrate this slide. So comorbidity. Before you start antihypertensive therapy, we need to look for the comorbidities. What group of drugs we can start? What are all the adverse effects we need to note? So, okay, this is a big slide, but it's very important. Suppose the patient hypertension with the coronary artery disease, means we need to first line start the therapy either AC inhibitors or ARB or beta blockers for patient with a stable angina. If it's not responding with these three group of drugs, we can second line is a long-acting calcium channel blockers or dihydropyridine calcium channel blockers as the therapy. But you should not use a short-acting nifedipine. Suppose the patient hypertension 150 or 160 90 with the MI, means you should not start a short-acting nifedipine because they lead to the hypotension and palpitation. So we should be very cautious. And also, if the BP is less than 60 diastolic, means you should not go for double or triple combination therapies. That also we should keep in mind. Suppose the patient is recently MI, 2 to 3 days back, the patient developed MI with hypertension, means already I told any heart failure, MI, something like that, means always consider for beta blockers, first line beta blockers plus AC or ARB. Suppose if the ARB is intolerant, we can change to AC is intolerant, means you go for ARB. And second line is a long-acting calcium channel blockers, but you do not use a non-dihydropyridine calcium channel blockers. That means diltiazem or verapamil if heart failure is present. So then what calcium channel blockers we can use, means cardioselective or other normal calcium channel blockers, we can go apart from the non-dihydropyridine calcium channel blockers. And suppose the left ventricular hypertrophy along with hypertension with the echo showing LVH means first line, because the patient is going for cardiac remodeling, can go for a AC or ARB or thiazide like diuretics, but do not use a direct arterial vasodilators like hydralazine or minoxidil. Suppose the patient is a heart failure, is a coronary artery disease, MI, suppose the patient already developed a heart failure means again beta blockers or AC inhibitors. Second line is the AC or ARB. If combining with the aldosterone antagonist to AC or ARB, monitor for the hyperkalemia. Whenever you start AC or ARB means keep in mind we should check any allergy, any angioedema, rashes, or any dry cough is there, and also always check a hyperkalemia when the patient started with the ramipril or enalapril. If combining the AC inhibitors and ARB, monitor the adverse effects like hypotension, hyperkalemia, renal function, bradycardia. In case of beta blockers, you should check this one. Suppose the patient is a stroke means with the hypertension. First line is AC or thiazide. Second is long-acting calcium channel blockers. Here also during an acute stroke, so considering for the thrombolysis means we should not reduce the BP extremely. I already told they will worsen the ischemic stroke, will expand the ischemia. Second is a diabetes with hypertension. The first line previously I told diabetes with the hypertension means AC inhibitors ARB is ideal drug. So loop diuretic should be considered in hypertensive CKD patient with extracellular fluid overload. Second is that is with the renal failure. Only diabetes and hypertension is again AC or ARB inhibitors. CKD with hypertension is AC ARB, but you should be very careful in checking the renal functions and potassium. So renal vascular disease, I already told, in case of the renal artery stenosis, we should avoid AC or ARB. So thank you for the patient listening. Any doubt, you can unmute and can ask. Even it's very paramedical students, physician assistant, emergency technician, even a very simple doubt also, you can unmute, can ask. Main, I want to convey that the method of BP recording, you should always record the BP as the patient to relax for 10 to 15 minutes after reaching to the hospital, and always prefer the left arm in the sitting posture to the heart level, 3 to 4 centimeters above the elbow joint, and then the tubing should be always in the medial aspect, so above the elbow joint, and record the BP slowly. And also while recording the BP, don't ask any question to the patient. We should not make them to talk. Even if they are talking and responding also, they're giving a falsely high BP. So you should avoid this. These are all the important points I want to convey to you all. Any doubts? Brother, can you finish?
Yes, madam.
Okay.
Madam, I think there is no more doubts, madam. You have explained everything in a crisp manner, madam.
Okay.
Madam. Once again, on behalf of JB, thank you very much for accepting, madam. And madam, one question is there in the chat box, madam.
Okay. Sleep apnea and hypertension. Komahal. Okay. Actually, sleep apnea is, hope you know, the obese patient. When the patient is very obese and there will be a grunting and the snoring sound will be there. There is a sleep apnea. With the hypertension, most of the time, so already they are obesity. That itself a risk factor for the hypertension because of the oxidative stress and endothelial damage leading to the hypertension. Extra, that obstructive sleep apnea, actually what they are doing is the lungs, in the chest wall, there will be a negative pressure when there is a narrow in the upper pathway. So because of the narrow pathway, they cannot able to breathe normally. So against the closed glottis, they are rushing the air to ventilate. So in case of the narrow with the hypertension means there will be a negative pressure in the chest wall leading to compressive venous return to the heart. So going for the right heart failure So again, that will worsen the vascular resistance, leading to increase in a BP. One is the obesity is a risk factor. Second is the obstructive sleep apnea, leading to the hypertension. Any other doubts? Any correlation with the premature birth and future CKD progression? Actually, exactly it's not know the data, but in case of the premature birth, so we don't know all the organs are developed properly or not. Suppose if they properly developed, not an issue. If they are mainly the kidney is mostly they will start secreting the urine even in the first trimester itself. If they are premature means, so always the prematurity is because either due to an infection or any other preeclampsia or eclampsia, something like that, depending upon the etiology for the premature birth. So if the kidneys is not fully developed means there is a possibility for renal damage, but is not a full-blown CKD progression exactly related to the premature birth. Is the overview for concerning with the etiology from premature and as the organ development. So that if suppose the patient is a genetical abnormality is there, means definitely there is a progression of multiple organ damage, not exactly the CKD. So, any other doubts? Sorry.
Thank you, madam.
Yeah. Okay,
Once again, on behalf of JB, thank you for accepting, madam. And it was a wonderful CME program for all the participation, I think. Once again, I thank you. Now you can stop the recording and save the file, madam, and then you can close the meeting, madam. You are the host.
Yeah, sure. Stop.